Hi, it's Ann from the Lowdown on Cancer. And as we begin to look a little more specifically at breast cancer, I'm very excited to be able to introduce you to somebody and ask questions and chat with somebody who's going to really share a bunch of information with us. So I'm going to cover her bio a little bit just so that you can see how amazing she is. Her name is Dr. Chalasani. Is that correct?
That's correct.
Okay. Dr. Chalasani completed her medical school at Gandhi Medical College in India, internship, residency, and fellowship in hematology and oncology at the U of A, yay, Arizona. Dr. Chalasani is an associate professor of medicine at the University of Arizona Cancer Center. Dr. Chalasani's primary clinical and research focus is on breast cancer, which is why we're talking with her today. In addition to seeing patients in clinic, she is very active in research and has several ongoing translational and clinical projects. She leads the breast cancer disease-oriented team and oversees breast cancer clinical research program. She has a laboratory, is the principal investigator on several trials, is the medical oncology study chair for NCI study in women with inflammatory breast cancer, and lead investigator for a randomized phase 2 trial in women with metastatic HER2 breast cancer. She's received research funding from NIH, NCI, American Cancer Society, Better Than Ever, and the University of Arizona Cancer Center pilot funding mechanism. Okay, all I can say is, wow, that's amazing. And given all of that, first of all, I want to thank you so much, because with all that, I don't know how you carved out any time for us today, but I want to thank you so much for that. And if you wouldn't mind, introduce yourself and give us a little bit of your background.
Yeah, well, thank you so much for this opportunity. And yes, I have a busy work schedule. However, one of the primary reasons I do what I do is so that I can talk to patients and educate. So this is one of the things that I consider as a part of my job too. So I really appreciate you giving me the opportunity for this. So as you introduced, I'm a breast medical oncologist here at the University of Arizona Cancer Center. I'm a tenured associate professor and I lead the breast cancer clinical research team. I also chair the scientific review committee, which oversees and vets the scientific rationale, like if the reason to do the study has the right scientific background, all the good data and support for all cancer-related clinical trials at the Cancer Center. My research interest is obviously in breast cancer. So at the Cancer Center, I have the opportunity to work with scientists who have expertise in diagnostics, prevention, treatment, and even post-treatment, like in survivorship area. So I get to collaborate with this amazing group of scientists and expertise we have here at the University of Arizona. And I help them in clinical trial designs, in translating and bridging their research to clinic. And so I kind of have that translational physician scientist is what we call. And however, I do have a lab. And in my lab, I focus on what we call as biomarkers. So these are markers or changes which can happen in the cancer tissue or blood or urine or just normal tissues, which can help us understand how drugs work, how they don't work, what kind of effect are they having on normal tissue, what kind of effect they're having on tumor tissue, which can help us understand how treatments are acting or not acting. And this would eventually lead in, help us in development of drugs, like which one works better, why they work better, like who to give it to, and equally important, who to avoid it so that we can minimize toxicity and unnecessary treatments and stuff like that too. So in addition to all this, my research interests, so I am also the program director for our hematology oncology fellowship program here at the U of A, where we train the next generation of hematology and oncologists and going from that.
Is the incidence of breast cancer rising, decreasing, about the same? And are we seeing a rise or a decrease in a specific age group?
So the incidence of breast cancer over time, it has been shown to increase by 0.5% over time. So 0.5% per year. So with that, and part of it is attributed to decreasing fertility and increasing body weight, and that has been known to be an attribution for that. In terms of age groups, I mean, there have been various reports, but I know younger women, they are getting, more younger women are getting diagnosed, but hasn't made like a statistical difference yet. But we do see an, overall things. There are certain biologies of breast cancer which are more prevalent in younger women, and they tend to be more aggressive. So I think that is also one of the things where the focus in younger women, where the cancer and where the mortalities are different compared to in general breast cancer things. The incidence of breast cancer, if you take it, let's say we say 1 in 8 women is going to develop breast cancer in their lifetime. If you just do a cross-sectional as an observation, right? As a cross-sectional, 1 in 8 women can develop breast cancer.
Very basically, how many different types of breast cancer are there?
Okay, so all of them are lumped under breast cancer. However, in the bigger things, what I always try to educate in patients are when you initially are diagnosed with breast cancer, we look for what is making the cancer grow, or what is that. So we look for 3 known markers. 2 are hormone driven. They're estrogen and the progesterone driven. And third one is a protein called as the HER protein or HER2 protein. So based on those 3, the broad definitions are if those 3 are negative, it's a triple negative tumor. If the HER2 is positive, it's a HER2 positive driven tumor. And then if the HER2 is negative, but the hormone receptors are positive, it's a hormone receptor positive, HER2 negative. Now, this is the broadest classification I've gave you in the bigger sense. There are a lot of interesting research which has done, which has actually subgrouped each one into gene expression and subtypes. Again, it's more for scientific and research interest, and some actually also aid in treatments. But in general, as an outline, it is those 3 types that we tend to put 3 baskets that we tend to group those biologies of breast cancer into.
And is that similar for both men and women?
Yes.
Okay. I'm fortunate to get to interact with a lot of breast cancer patients. And, I'm always a little surprised when I ask one of them, well, what type of breast cancer do you have? And their response is, well, my doctor told me I have the good kind. What's the good kind?
So typically those kind of things are, the terminology is used for hormone-driven cancer, which is not triple negative. So hormone-driven cancer, HER2 negative. That was traditionally the scenario. And the reason came about is when we were trying to learn about breast cancer and we were trying to understand, okay, what is driving it? The first initial studies were, these were all patients who got surgery done, right? And we didn't have any treatments. At that time when we were trying to understand, and they found this estrogen-driven cancers, those patients did better than estrogen and non-estrogen-driven cancer. So in that sense, it's a prognostic. It gives good prognosis. But later, but it's also good because we can target the estrogen receptors and the progesterone, right? So that is what it started off. So HER2 protein, however, has a whole different story. Like even before, I was in training or things like before 2000, having a HER2 positive cancer, whether it was estrogen driven or estrogen independent, the HER2 is a very aggressive clone, a very aggressive gene. And it's almost like you put a key and turn the gas and turn the engine on, and it's just like going and going. So, but targeted antibodies were developed. Herceptin came around, and then now we have Perjeta, and then Kadcyla, like TDM1, margetuximab, and HER2. There was just huge amount of research developed to generate treatments focused on those antibodies specifically, targeting the HER2 receptor. And the prognosis of patients has changed dramatically. So there are, since 2018, we use a new classification for breast cancer. And we use what we also integrate the biology, the estrogen, the progesterone, the HER2 biology. So in this day and age, HER2 positive tumors actually has a favorable outcome because we have targeted drugs, which we didn't have before.
And it makes sense. So having said that, is there a bad breast cancer?
So It's hard. I mean, I don't want to use a good breast cancer or bad breast cancer. What I try to tell patients is they have breast cancer. This is the biology. These are the treatment options. Triple negative tumors are notorious and they might fall into the category of bad, but there's a lot of research going on. We have this. I mean, yes, it's chemotherapy. We don't have targeted treatments available, but I'm just going to say yet. That's all, because I think we will make progress there. It's going to take time. It's a little bit more difficult. So it tends to be more aggressive. Is it bad? I mean, I think that is not the right terminology we should do to any patient, because first of all, no one needs to have cancer, and whether it's a good or a bad type, so sometimes even for the good, like I tend not to use it. And it's a conscious thing that's, all of us have to make effort to learn, because even with good, I mean, they go through surgery, radiation and treatments, and we shouldn't undermine, and they shouldn't be thinking, oh my God, I'm grateful I had this and not the other one. I mean, there's nothing to be grateful for. All the treatments and the side effects they're going through, they're still undergoing tremendous stuff. So I think if they want to just like feel bad and why thing happened to me, I don't think that is okay. Even for the good tumors, right? It is still cancer and they're still undergoing a lot of treatments and side effects from those treatments too. So while the terminology is used, I think we are trying to do better about trying to stay away from that in practice now.
Yeah, well, my feeling on it is all cancers are bad. So
exactly.
So I get that. Yeah. Which types of breast cancer have the highest recurrence rate?
So that's the triple negative tumors, which do not have targeted therapies, and HER2 tumors, which are high risk. So when we think about the 5-year mark, which is the magic, a lot of times people focus on that. But so the triple negative tumors and the HER2 positive tumors, most of the times, because they are very fast growing and aggressive tumors, so if they were to recur, they happen within the first 3 to 5 years. Very rarely they kind of linger around and come back like 10 years later or 15 years later. So those good prognosis are the good type of tumors that frequently patients are, but they do well, because we have a lot of good prognosis or things, but they always have a constant risk of recurrence for a lot of, for the majority of their lifetime. And especially younger women, if they get diagnosed with this estrogen positive, HER2 negative tumors, especially if the lymph nodes are, involved at the time of diagnosis, that constant risk actually continues. And then the longer you live, the longer you're going to see it come back and potentially affect. So majority of the times, granted, there are always going to be some outliers. Majority of the time when you hear the scenario where someone tells, oh, someone I know or they personally had breast cancer 10 or 15 years ago and it came back, they're talking about those estrogen positive or hormone positive HER2 negative tumors, because that HER2 clone or the triple negative clone doesn't tend to linger or stay, without activation for so long in majority of the scenarios.
When you factor age and gender and race and even obesity, who is the most at risk for getting breast cancer?
Even if we kind of balance out for the age and obesity, African Americans do have a higher risk of developing triple negative, higher stage of breast cancer in general compared to whites or Hispanics, and have a higher incidence of mortality from breast cancer related deaths. Certain biologies are more aggressive in some ethnic groups and racial groups, and that is triple negative cancers especially, and they tend to have a higher recurrence in mortality too. So there's definitely some disparity there that we need to investigate what exactly is driving in certain groups more than the other. And obviously the other things do factor in terms of socioeconomic status, access to medical care. So those things do influence, but even if you try to balance it out, there is something which also drives those biologies and mortalities and aggressiveness in some groups that we still are trying to understand. There are certain genes which have been known to be more active with obesity and in some ethnic groups like Hispanic groups. And so is that one which is driving the mortality or things? So there's a lot of research going on to kind of figure out what exactly is driving and to kind of help us understand this disparity and what we can do to address it.
Well, fortunately, we have people like you who are trying to figure it out for us. So we're on a good trajectory, I would think. Now, our own medical director has stated that 90% of all cancers are environmental. Is that your assessment as well?
What I would say is, I think majority of the times we don't know. So that is the whole thing, because the influence of environment, like chemicals that we breathe or what exposure we are going to have, it is going to be very hard to tease it out, what degree and why certain groups and why certain not. So there is a multitude of things which could play into, like, yes, there could be something in the environment which triggered a certain gene, like a metal, some kind of gene abnormality, but what made that person more prone for that? Is that environment related? Is that something they were born with, or is that something over time they acquired? Those things are still too hard to know. What we can say is, there are certain breast cancers and and a lot of cancers that we know are associated with some gene mutations that we have found. And we are learning, some are, and most of them are genetic, and we are constantly learning more and more genes which could actually be mutated and cause cancers. Some of the gene mutations could be caused because it's a familial thing and they inherit it through them, or it could be happening because of various reasons. So those could be environmental, those could be other triggers which are happening, which trigger a different gene, which influences this gene and how it expresses or how it influences. So there's a lot of things going on. What I would say is, majority of the times we don't know. And unfortunately, that is the answer I also give a lot of my patients, who, especially young women, who also come in and say, why did I get this? I eat right. And just not a young woman, all patients who are, majority of the times we try to take care of ourselves, they still get it. Like I said, 1 in 8 women gets breast cancer. Not all of them have genes. And the reality is, most of the times I'm like, I can't pinpoint why exactly you got it. I just don't have one trigger factor to say this is what caused it.
So how much of a factor is genetics?
So in general, for all breast cancers, if we say about 5%, but if you look at the subtypes, like in triple negative breast cancers, it's almost like 10 to 15% of breast cancers, or sometimes even the more we are learning, like it's going up to 20 to 25% is genetic related, but not for the other subtypes, right? But if you combine all breast cancers, it's about approximately 5%.
So the one genetic mutation that I think almost all of us know about is the BRCA gene. Mm-hmm. What other genes have they discovered that are having mutations that are specifically related to a cancer diagnosis or a breast cancer diagnosis?
So, the ones that you mentioned exactly, and, the BRCA, so they have the BRCA1 and BRCA2. So we have 2 genes there and they have mutations. Those are the ones which have been discovered first, to kind of cause this, okay, there's a mutation in this gene, someone is at risk of developing breast cancer then. Now we have gene panels which look at a lot of these genes which actually work on repairing DNA. So that is how BRCA genes work, is they work on repairing DNA. So when there's a mutation, they can't repair the DNA, and then, the cancer thing. So we have other genes. So like there's a CHEK2 gene, PALB2, RAD51, ATM, ATR. So it just like went up, like learning, the mechanism. So the BRCA kind of started the whole thing, but then we realized, okay, there's so many more genes in the DNA repair pathway. And then that led to other things. So now we have large panels of genes testing that we do, like germline mutations, and we are learning more. And there are, companies for genetic testing that, as they're learning more, they're also, maintaining databases. And sometimes we had, like a few years ago, and they're constantly updated, right, on this database. So what 10 years ago was, we don't know, it was a variant of unknown significance, but now could be classified as pathogenic, knowing that it is known to cause, and this is the incidence, like actually giving us information because of the testing which was done and the database and the data we collected in history. And okay, how many patients, how many people with this gene actually got breast cancer? So is it really there? So we are getting a lot of like variants of unknown significance, but with the constant thing. So at this time in practice, like I actually talk to my patients and almost send them for an updated genetic testing, especially for those I think there's a high risk of some kind of genetic mutation. Always go back for an updated genetic testing like every 5 years, if not more, because the panels are changing all the time.
I know that with a BRCA positive diagnosis, there's often some prophylaxis recommended, mastectomies and hysterectomies for women that are men and women that are BRCA positive. Of course, men don't have hysterectomies, but anyway, so in some of these newer mutations that you have seen and that you've elicited, you've talked about, are there other types of treatment and
for prevention
and that kind of stuff from those?
So we don't have it. So the only ones we have right now in practice is BRCA1 and BRCA2, because the other genes, we don't have that. The knowledge, the identification has gone up, but we don't have that kind of data to actually say that if we do mastectomies, it is going to change their outcomes. We don't have that. So, when you're thinking about that, so that's where we have to like weigh the risks and benefits. But if there is a mutation which does make someone a higher risk of developing cancer, they can go into a high risk surveillance program, rather than a standard mammogram. So those kind of things are there. And there's a lot of potential prevention strategies that we could, offer them, right? So, treatments or, medications or whatever other prevention strategies we can kind of focus on that high risk group at risk of developing.
What are some of the lifestyle factors that contribute to breast cancer?
Obesity is one thing, and decreased, the fertility has been shown, has been known as overall. But decreased activity, and just in general, I think the more active you are, the healthier you eat, the better it is. There's not one particular thing, like one particular diet, which is a magic diet or anything like that, which would help prevent it. But I think the critical thing is eating healthy and less processed food, no matter what. And I would strongly advocate for all my patients, and I tell them that we don't have to change any diet, but if we can cut down processed food and eat better, that is a huge step there. But in terms of the risk factors which have been shown, it's not like one particular diet which has been diagnosed, but obesity has been known risk factor. So there are a lot of diets which cause obesity, right? So you have like indirect things there, but it's obesity and infertility.
Can you speak more to that about the infertility? What kind of relationship is there?
So the main thing is a delayed age at first birth. How the age group which is increasing, that has been known to have a risk factor. Previously women were having kids early on, so in the early 20s or even like late teens and early 20s, but now the age of having your first kid is like increasing. So it's a linear, it's not that one time point. Traditionally, when we were learning, it's like, over 30 or less than 30, but now majority that over the group for the age of first kid is increasing because of, education and more women working. So I think it will change maybe later on, like the age of like less than 30 or more than 30 before. But at this time, like I said before, that's how we define it. But I think, the older you are, I think the risk kind of increases with that.
And does, infertility treatment contribute in any way?
Not infertility treatment, just not having kids. So that is what it was. And so it's older age or not having any kids, because pregnancy is supposed to have some protective effects. Now, there are some cancers which happen in pregnancy, but in general, overall for the population, pregnancy has some protective effect.
What indications for self-diagnosis that would make a person need to see a doctor?
So There's not a particular sign or symptom in general. Frequently, a lot of times it is you notice changes in the breast. So you feel a new lump, or you see, or you feel a new lump in the breast, or inversion of the nipple, like the nipple is going inside. You have a nipple drainage, pain, and then you feel a lump or a mass either in the breast or in the armpit area. So a lot of things, so one of the things, the inflammatory breast cancer, which is a very aggressive subtype of breast cancer, is where frequently is diagnosed as infection, and it does look like an infection. It's just red, hot, it's very warm to touch. It hurts a lot. You can't feel a mass or anything per se, because the entire breast is like swollen and looks like it's infected. So frequently treated with antibiotics like mastitis or things like that for like few courses, and then it is there. So it's a whole spectrum of things. But the main thing is, if there is a change from baseline, that needs to be investigated. That's all I would educate, or try to, if I have to tell one thing, is if there's ever a change, just go and get it tested.
Yeah, no, that makes sense. What are the most important actions a person can take for self-diagnosis? And is it the same in men and women?
Yes. So the main thing is, like I said, for men, they don't have a lot of breast tissue like women, to do that. So in that sense, they may be able to feel changes or notice changes more rapidly. However, they have a very low suspicion of developing breast cancer, right? So they may not think it is breast cancer if something is changed, notice some skin itching, or like a rash around the nipple or the surrounding area. They may not pay attention to that, but that could be an underlying, precancer, or like Paget's disease or other breast cancer. So because they know that is not the first thing which would come if someone notices change, if men notice change in their nipples or their chest area. For women, it's the same thing again, any kind of symptom. So, you would do that. So they can talk to their gynecologist, primary care physicians, or call any kind of breast center, ask for someone to evaluate them, and they should be able to, and then get imaging done appropriately based on that.
Does breast density have any kind of correlation?
Yes. So, increased breast density has been known to be a risk factor for breast cancer. And the other thing is, really dense breasts make the current screening, like mammograms, not very effective. So there are some breasts, like, when we review some scans and some images for really dense breasts, and it's hard to like see what's going on. So MRI breast, for breast MRIs and that have shown to increase some sensitivity and doing that, but it is a known risk factor for developing breast cancer, and also gets hard to use the current techniques that we have in that group too.
What are the biggest challenges in breast cancer prevention?
So I think one thing I still feel like is access, and where people getting all of that, getting it. So yes, it's not perfect, like even in dense breast, but we still have mammograms and, maybe ultrasound setting, and dense breast, if they have a high risk, maybe using MRIs, but it is not still utilized, and there is still an access to care issue. So that is one thing, definitely. We can do better in terms of improving our diagnosis capabilities. Like I said, mammogram is not perfect, so we need to improve that. So they are actually working on that. They are using some low dose, like, studies on going for low dose CTs, which actually don't have any more radiation than a mammogram would have been there, but actually has a better way to look at breast and the density as in a 3D way, even different from a 3D mammogram. So they're looking at better diagnosis there. So that is one thing. And then, so these are all for like, initial diagnosis and follow-ups, and for which will help in high risk patients who are at risk for developing. And then strategies of what we can do to prevent diagnosis. So right now, some of the medications that we use for treatment for breast cancer are also used for prevention of breast cancer, like tamoxifen, raloxifene, and all the aromatase inhibitors. So that's a group of drugs we use in hormone receptor positive breast cancer. They're also used in prevention, or someone who did not have diagnosis. But those are still medications. So a study for the tamoxifen, which has been standard, like a a full dose having a lot of side effects. But most recently, a few years ago, there was another study which came out looking at a much lower dose that has significant lower side effects. So that was good. They're looking at a topical like gel of tamoxifen applied on the breast so that it can just be more locally and not actually there. So that is an NCI prevention study. We actually at the university participated and actually have quite a few patients and not patients, I'm sorry, participants in that because these are all healthy women. And yeah, and we are looking forward to like more of those things, so that we don't have to take it, but see if we can change the breast density and see how things are. Obviously, diet and exercise and other things I think are huge. And, those all play into how we take care of ourselves, how our body addresses inflammation, how our body addresses to changes to any kind of environmental or other kind of insults or injuries, which we are constantly up against every single day without realizing, right? So that kind of build, like strong build in our body depends on what we put inside. So diet and exercise are critical. So there were some studies done in the invasive setting, like in ovarian cancer, like 30 minutes, at least 3 times a week of aerobic exercise has shown to decrease recurrence. There are studies ongoing in invasive breast cancer, for weight loss and exercise and things like that. But, the same thing's also here. So every time I see patients, I'm like, okay, so how much are you exercising and what are you exercising? And I ask them to get all the details for that, just because I think it's important. Once someone is diagnosed or is at known at risk and you get scared, and it is scary, there's no doubt about it. You wonder about recurrence, but the number one thing which still kills women is heart disease, but also one of the best thing we can have against fighting anything is also keeping ourselves healthy. So it's important to be focused on exercise and diet. I don't have a regimen to recommend in randomized trials, but I think that's just critical part of being healthy. And that is important for every single patient.
So I was diagnosed, it'll soon be 7 years. And, standard therapy at that time was surgery, radiation, and/or chemotherapy. Is that pretty much still the routine, or has that changed a bit?
So those 3 modalities are still there. I mean, chemotherapy, again, it depends on the biology, but, chemo are hormonal therapies, right? So those still are the mainstay of conventional treatments which are there. But what we are learning to do is there a group we can avoid radiation? Is there a group we can avoid lymph node biopsies? So those are all actually coming into play. So there are choose wisely guidelines by the American Society of Breast Surgeons. And we have data from radiation oncology in terms of a group we can potentially avoid radiation without making a huge impact on their survival or things like that. So those are all things which are available, and we talk about it. So our multidisciplinary team meets every single week, and we review every patient to figure out if that is the best approach, and making sure is a lymph node biopsy there, what kind of surgery, and then what kind of breast surgery, what kind of lymph node biopsies, and radiation, yes or no, and then from medical oncology perspective, what kind of treatments are optimal or things like that. There are certain, for estrogen receptor positive cancer, traditionally, chemotherapy was offered for a lot of patients, but then subsequently gene assays were developed, which actually, these are not genetic mutation, but these are gene testings of the tumor, which could help tell us if that cancer does benefit from chemotherapy or not. Since those assays came along, for the estrogen receptor positive, HER2 negative subtype, like the chemotherapy is avoided in 50 to 70% of times now, because of that kind of personalized data we are able to come up by testing the tumors.
Wow. And are you referring to an oncotype?
That's one of the tests we use, yes.
And my understanding is those are typically done on patients that are not HER2 positive and do not have lymph node involvement. Is that correct?
So it is approved for premenopausal women who have lymph node negative tumors. But as of December 2020, now for postmenopausal women, it's both for lymph node negative and up to 3 lymph node positives. And
Wow.
that data is just was presented at San Antonio in December of 2020. And it has shown that in postmenopausal women from 1 to 3 lymph nodes positive, if you do an Oncotype DX, again, up to 25, there is a, minimal benefit. I mean, there is going to be some incremental because it's a continuous score, but it's very minimal that you can potentially discuss about avoiding chemotherapy. We don't have that for premenopausal lymph node positive yet. And I think, it's always going to be hard because to tease out, how much of the chemotherapy caused their ovaries to be suppressed. So is it truly the chemotherapy or is the chemotherapy causing the ovarian suppression? And that would be a very hard, it would be a study which would answer, but I don't know if the study could be done in a realistic manner because randomizing versus not randomizing young women to chemotherapy would be a hard thing. But, that is very hard right now.
Is the number of lymph nodes involved indicative of a higher risk of recurrence?
Yes, it is.
Where's the line?
I mean, so, the lesser the lymph nodes, how big the lymph nodes are, is there, are they near the capsule? Are they like, bursting out of the capsule, like what we call as extra nodular extension, the pathology report, the size of the lymph nodes and the number, they go. So 15 lymph nodes involved is different than 1 lymph node with a 2 millimeter metastasis. So there is a difference in how it looks there.
So what is your advice to patients that have completed treatment to avoid a recurrence, or is that just a roll of the dice?
The thing is, a lot of times it's a risk versus benefit, and frequently, there's no denying chemotherapy or hormonal therapies, whether it's a pill. And like I said, none of the good prognosis tumors, it's not that their side effects and things are there. So what I would tell them is talk to the oncologist and have realistic expectations. I think when I try to talk to patients about treatments, my goal is to not recommend saying, oh, you need to do this and be miserable for 5 years so that your cancer doesn't come back for 2% or 3%. I mean, those kind of numbers I think are hard for anyone. But the thing is, when it comes back, it is majority of the times it's a metastatic recurrence where it becomes terminal or things. So those things are hard when everyone kind of thinks, oh my God, my quality of life is going to be impacted. Most of us come from the side saying that I think if your quality of life is going to be impacted, we will stop it or do it. Most of the times the side effects are reversible, and they can resolve. But I think that discussion and having information on what the side effects are, and Google is awesome and it opens up, and web is amazing because it gives you an opportunity to talk to other folks who are in similar conditions. But we also have to take it with a grain of salt in who exactly are being vocal and how they are reporting their symptoms. Either the ones who are completely going through and having no issues, or the really severe ones. So there's always a little bit bias in the reporting. So whereas the majority actually fall in that category where they have side effects, but it is bearable or tolerable. What I always try to talk to everyone, every single one, is I do not know what bearable or tolerable is for a individual person, but that is what it is majority of times it's bearable or tolerable. While the side effects listed are extremely, concerning, there is no doubt about that, but it could be bearable or tolerable, and we would not know. So I always try to say we are hoping for the best, but we're also prepared for the worst case scenario, and we will go over that. So that risk versus benefit scenario is going to be continuing as long as they take any treatment. So in that, giving a spiel about why I think it is important, because all these advances we have made is because of therapies. So and now we are also actively looking into treating and peeling out therapies. But I think when someone comes in and wants to peel up all the therapies at the same time, then most of us are in a data-free zone, and I do not know. But these are curable cancers right now, and we are looking actively at peeling away therapies. While it may not help someone at this time, but maybe in the future we'll be able to. So we are actively looking at that. So I would say have that discussion with the oncologist. In terms of what else they could do is coming up, whatever regimens, like I said, but exercise and eating healthy. Like I cannot emphasize enough on that. Is trying to be active and decreasing processed food and just eating healthy is the critical part of it. It is important to take care of yourself, and wellness and mindfulness, those are critical. I cannot emphasize, enough on those kind of activities to take care of someone's well-being, to de-stress and decrease inflammation and things like that. I can't have a randomized data for every single thing. They are doing some studies, but those are common things which are critical. So those are all things that I routinely talk to patients when I see them, and continue to see them and continue to follow and ask them where they are.
That's great. And that's great advice to avoid lots of health issues. And to your point about how side effects are different and what's tolerable for everybody. I interviewed a scientist at one point, and he said, really, every cancer patient is in a clinical trial of one. And, I wish I had heard that before I started therapy, because for me, there was a lot of comparison, how was I feeling compared to somebody else? And that just is not a good thing.
Exactly. And like we were talking, what is tolerable, bearable, I do not know. Like someone's pain threshold is different from someone else. So a joint pain, which is unbearable for someone who is mentioning it online, could be bearable for someone different. So, it's all relative, because it's all subjective. And we should not undermine anyone's symptoms. I don't think most do. I never undermine their symptoms, but I also don't want us to go into thinking, I'm going to have all those things. We never know. Yes, you might, but then this is how we will address that. And, we just have to take one step at a time. And like I said, I'm a strong advocate for quality of life and maintaining it. I mean, I think I would not want to take a pill for 5 years if every single day I'm going to be miserable. I think that's just the reality, right? I do not want any of my people to be that too. So it's important. But however, I do not know who is going to have it or what degree they're going to have it. Is that important or not? So, that is where we have to have a discussion and doing that. And if there is, then stopping it so that it is not changing or things like that.
Is there anything else you would like to share with us about breast cancer that maybe I haven't asked?
So we've made a lot of strides in breast cancer. The mortality has been decreasing, but there's a lot of things we still need to do. But what I would really want everyone to know is when they're talking about, am I getting overtreated? One of the things is everyone is actively working on de-escalating or like decreasing therapy in the right group. We don't want to peel off on everyone and take a backward step with all the advancements and the cures we had because, of the concerns of the toxicity. There is an actively researching, and survivorship, like I told you, it's huge to look at toxicities and, how we can decrease it and what things are. So, have a discussion with your physicians and, just go from there before deciding no for therapies. But there is a lot we have to, we still have to do, but I think the engagement and the interest and the technologies are developed so fast that our knowledge is also skyrocketing, and more and more team science groups are doing it. It's not anymore one researcher working on it, it's all groups and teams working on it. So the progress is also going to be rapid. So in this stage, I'm kind of like looking forward to all the advancements we can make. So at some time point, we can say it doesn't matter what stage it is, we can cure. With the good quality of life, making sure you can still do what you want to.
That would be amazing. That would be so amazing. Yes. Well, I just want to thank you for taking so much time with us today. And I just appreciate everything that you've shared. And, thank you for all you're doing to advance the research so that, like you say, at one day, regardless of the size or the stage, that you can cure it. So I just want to thank you for all that. And again, thank you so much for your time today.
Well, thank you for having me on this.
Thank you for watching the Lowdown on Cancer presented by the Cancer Fund. To learn more about what's coming in future episodes, visit us at www.cancerfund.com. While you're there, check out past episodes and be sure to click join us to become a member of the Cancer Fund community. As a member of the community, you'll receive early access to new interviews, as well as other announcements. Make sure to connect to all of our social media channels so you don't miss a thing. In addition to getting early access to new episodes of the Lowdown on Cancer, Cancer Fund members play a critical role in driving cancer innovation forward so that one day we can more than hope. We can actually beat cancer. Thank you for joining us on this journey.